Good afternoon, everyone. Welcome to our 19th Echo Session. We want to welcome everyone, but because of time, we'll just say welcome, and we hope you can hear us. If you can hear us, please just wave your hands. I'm very excited. I can see Nyimba. I worked in Nyimba for a very long time, 1.5 years before I came over here, so I'm excited about that. In the hub today, we have our colleagues from the World Health Organization. We have Dr. Chitembo, we have Dr. Boyd, we have Minesh from CDC, we have Dr. Mulenga, and of course, we have our team from the Adult Center of Excellence, Pediatric Center of Excellence, and I'm very excited. We have a team from Kafue, represented by Pezo. So we'll go straight into it. I think we'll have a short recap on last week's topic, which was index testing, before we go into today's topic, which is really looking at the whole HIV program in Zambia, where we are and where we want to go, and what are the government's commitments to the COP plan for 2019.
Good afternoon, everyone. I'm going to give a brief recap on last week's session. So our topic last week was on index testing and self-testing. So we did learn that Zambia still has alarming HIV testing gaps, which is approximately 30% of people who are unaware of their HIV status. And this is our first 95 target in the cascade. So the gap exists in spite of us having free HIV counseling and testing services across the country. And these gaps have been attributed to various reasons. And so Zambia, to address some of these gaps, we have adopted self-testing and index testing. And these approaches will actually help us reduce the testing gaps. And I just want to mention also that we do have the guidelines that are addressing HIV testing and self-testing. And the presenter last week did labor a lot to also explain the difference between index testing and household testing. So household testing is testing everyone in the household, but index testing really is testing individuals that have direct contact with the case index. We also looked at, there was also an issue of we should not only emphasize on individuals that sexually active, but also you can target the adolescents. We can also target the elderly women and all those that are indexed to the index case. We also did look at HIV self-testing, and HIV self-testing is not targeted for everyone. It's targeted for specific population, especially the men, and also that the distribution of the HIV testing kits should be targeted to those populations. And maybe just to wrap up the summary or the recap, where I would like to remind ourselves that in HIV testing services, we still adhere to the 5 C's, and that is consent, confidentiality, ensuring that the results are correct, and also that there's counseling and education. And most of all, also remembering that all those that are tested must be linked or connected to treatment and care. That's a brief summary. Thank you.
Okay, so we'll now go ahead with the presentation from Dr. Mulenga. Dr. Mulenga, you are welcome.
Thank you, Dr. Sombo.
You can go ahead.
Good afternoon. Mary, how are you?
I'm well, thank you.
You came panicking. Afternoon, team. It's good to discuss where we are as a program and what we need to do, especially as we look for epidemic control, which may be in sight. So the presentation is going to highlight what we did present to the leadership of PEPFAR and also the leadership of the ministry as well. This is in a meeting which happened more than a week ago in South Africa for us to plan for the period September 2019 to October 2019 to September 2020. So this process has to be done every year, where we have to look at the program and also have to look at what is working and what is not working. And in this, we also highlight some strategies for testing that may produce better yields, and also look at the gaps that we have in case findings, like children, adolescents, girls and young women, and also the men. And also how to look at retention, which is an issue. Of course, not only in Zambia, it's across other countries as well. And I need to say that I think you are doing so well. Several times we come to you and say, you're doing badly. But we are doing well, we can do much, much better. When you mix with other countries, then that's when you see that these challenges which we there on how to address these challenges, because we know that you have the answers. So in this planning process, there's also stakeholder engagement, which had been there for several months. We had been meeting under the coordination of the National AIDS Council, where you have the USG, WHO, UNAIDS, civil societies, and we have the PEPFAR planning meeting, which was in March, the one I highlighted. Then even after tomorrow, we are going to give feedback to the same audience, the stakeholders, on what I went through, and also to the senior management of the Ministry of Health. Now, this is where we have an estimated 1.2 million people living with HIV in Zambia. So we have the one in darker blue is the UNAIDS targets, then of 95. Then we're comparing to the Q1 FY19 results.
Okay, you can just go on.
So when you look at with the first 95, you can see that 89% of people living with HIV, we have had the testing done, which is impressive, about 89%. And again, compared to the same percentage of the people living with HIV on treatment, 952,000. And I need to say that this is the latest data which we have from the ministry using HMIS. As of last night, the data which was reported was 998,000. So we are close to 1 million on treatment. Then on viral load suppression, again, 849,184. This is a mix, of course, of looking at the Zambia data, using the viral load suppression data, then also looking at the programmatic data as well, coming up with those. And the populations where we have unmet need, again, this has been emphasized. I remember the first session we had for ECHO, we were emphasizing these same populations. So again, you can see that we have concerns. You need to concern the unmet need for those which are in yellow. That's where we should concentrate on. And you can see that the 15 to 19, the 20 to 24, and also look at the population for the male as well, 30 to 34, 25 to 29. This is where we are having the challenges. And our concentration as we go to somewhat, people say the last mile, is to figure out how best we can reach out to these populations. I need to emphasize that there are certain practices which have had a high impact. And the first one which I need to say is that the political leadership has been quite high. From the president himself, very soon next week, there will be campaigns going on using the First Lady. She's even inviting is it 7, Dr. Chitembo, first ladies from other countries?
That's right.
We're going to talk about, they should be launching the Ending AIDS.
Free to shine.
Ending AIDS, then under Ending AIDS, there's Free to Shine, there's the Reaching Men, and also the children issues. So all these issues which you're addressing, the First Lady is going to delve into those issues so that we can concentrate on those issues in the coming years and also maintain that momentum which we have built. We have to employ the mentors, the provinces as well out there for the progress which has been made in terms of finding the daily targets and also granular planning at facilities. This is very key if we are going to reach those numbers that we have not reached yet.
So Dr. Mulenga, on that first graph, I noticed there's, on the men over 50, there's a big gap there in our aging population, isn't it? I saw 45 to 49, but also more than at the men over 50.
Which graph, Doctor?
This one, there's 16,204. And these are people more than 50 years of age.
Yes.
Okay.
Then when you look at the accelerated activities over the SAGE, you can see all the provinces, of course, themselves have been accelerated activity. I would have loved Muchinga to be connected and Northwestern and Northern as well, you know, and Luapula. Western, we are there, we are able to see. Of course, we've seen an increase when you compare the darker blue, that is the FY 18, then compared to the 19. But I think we need to congratulate aiding regions such as Southern. We've seen a lot of increase. You can see just that there's been rapid increase in the treatment current. Lusaka and Copperbelt, of course, if we can concentrate on these high volume sites within the provinces as well, I think we are going to have better yields and we are going to cover more patients that we need to put on treatment.
I think you need to explain the FY to the Ministry of Health counterparts. FY1.
Yes, I think that's one disclaimer I forgot to mention. We don't have a case today because we want to give you a lot of time for your slides, but also the abbreviations need to come out because we may not understand what FY.
Okay. So, you know, the way we look at our quotas as ministries, we look at the quarter one, we start in January to March. Then again, in April, we go into quarter two. Now, where Mary comes from, they don't look at it that way. So where Mary comes from, they look at it from October to this October, November, December, that is the quarter one. Then again, you know, so if we are talking of this current year, we are comparing to the last year, that was the 18. Then when you compare to what is happening, the quarter one for 19 is what was happening, the results which we had from October last year to December last year, then you compare to the previous year. So when you're comparing these quotas, don't look at the quotas the way we look at them from the ministry side. We are comparing to how PEPFAR reports them. Mary, is that a correct interpretation? Where I don't get these things, ask Mary.
Next slide.
I remember emphasizing this slide, the first echo session we had. And I think the second presentation I did make as well. It's emphasizing on the case finding, linkage, retention, and viral load. And the rest of the slides like to go through this so that we can understand where we are, and it can also make us plan for these coming months and also for the coming year as well on where we need to emphasize. So case finding, index testing, 13% of HTS, that is HIV testing, the positive ones, that's where we have, you see the yield there. When you compare adult and pediatric, we have 26% yield in the adult, as opposed to 4% in the pediatric. Of course, there are certain things that have helped. The policy which was done for index testing and also partner notification. That is very key. And as the ministry, we are going to advance all well-meaning policy documents out there so that we can save the people. And this is one key policy document which we have also, which we do appreciate on having the index testing and also partner notification. Then when you look at the index testing going to scale, how did we move? We had 82% offered. Look at the acceptance rate. Impressive, eh? 93% accepted. Then contacts tested, 93%. The yield, 16% of the new positives. So for me, from this slide, what we need to emphasize is that if we do this rightly, there is high acceptance. Let's move from 82% offering this, let's move to 100%. And again, when you look at the other figures are looking at the different populations, those were the age groups were indexed, and also how many partners were identified. That's what it's emphasizing. But the bigger picture, just to say that we have high acceptance rates when we do it right, and I believe we can do it. We can do it well. And you can see at the contacts reached, women 25 plus, and also the 36% men 25 plus, then adolescent girls and young women, then the boys as well, and also the children. So let's do this and let's move on. Let's look at the challenging populations. On the panel here is Dr. Chitembo, and Dr. Chitembo is a pediatrician. We've been struggling with pediatrics. Dr. Chitembo, I'm sorry, I'm not going to put you on the spot. Dr. Timala.
We can download the Zoom application. There's a code issue here.
Apologies, we'll try to manage the participants at this point. Somebody is not on mute.
I think, Dr. Chitembo, the pediatrics, so when you look at this slide before you come in, it's, we are having PITC, of course, has been a major thing in the pediatrics, and this is what we've been relying on largely. So when you look at, of course, the amount of positives that identify, 27% of identified positives are coming from the PITC. But look at the yield. It's 1% of the yield. And look at index testing, 27% of identified positives are coming from there, but with a yield over 4%. I want to look at the TB clinic, and you see this from also the other adult data as well. You see that we have 16%. So we need to look at where are we having the best yield for as we do the programming. And for pediatrics, I don't know, Dr. Chitembo, what you may have to say over pediatrics and how best we can move in.
I think firstly, for the country, it's important to understand the data, because it's the information once we analyze it, and it tells us PITC since 2007, we've been doing it. Everybody goes to the hospital, we test. Mm-hmm. So now it's time to reflect. The data is showing us that perhaps we need to change the direction. So perhaps issue of screening the clients and not necessarily testing everybody. And I guess the discussion today, as we move on further in the further slides, as well as the further discussions in the subsequent weeks, we must come up with a resolution, perhaps by the end of this month, the direction that needs to be taken.
Sorry, Dr. Foloshi. I'm sure this is not how you routinely present your echo.
It's okay.
Trying to be interactive, and if you allow me, you're my boss, so if you allow me, we can go on.
Permission granted.
Okay. So I think it's important, this measure which is coming out by the end of the month. Dr. Chitembo is telling us that by the end of this week, we should come up with policy pronouncements which are going to affect the program. Thank you for putting us on the speed.
The math is like April. That would be unfair to say.
Okay. Yeah. Anyway, we'll work towards that so that we can see how this data can inform us in terms of policy implications. And we are grateful, Dr. Chitembo, for that and for pushing us in many areas. When you look at the reaching men, again, this is similar. Look at where we are having the highest yields, 24%. When you look at the index testing, 14% of those were identified. But also look at the VCT, where we have 38% of identified positives, yes, but the yield is 4%. TB clinic, we have 19%. So again, to me, this is similar to what we saw on the pediatric side. So these populations where we're struggling with, I think we need to utilize the data on where we need to concentrate on. I'm glad I have to say that there are policies which have worked very well. And I implore those policies which have worked very well. And they have led to us now observing where we are. And I think it's time for us to look at things differently now. How do we best utilize, or how do we best reach these populations which we are not able to reach? Now, this slide, it's a slide showing us the number of tests that have been done, and also looking at the, you can see that we've been doing a lot of tests over time. Look at from 2017, Q1 to 2019. Of course, for 2018, Q4, we had 1,718,000. For 2019, Q1, 1,697,000. So we've been doing a lot of tests. And what we need to answer is maybe we can do less tests, especially now that we have a lot of people that are already tested. They know their status, and some already on treatment. So maybe we can use the data to inform us where we need to concentrate more as well. Now, we are doing a lot of tests in VCT and also PTC, the PITC, but the yields are very low. So whereas we are getting a high number of identified positives, and some of these identified positives, we can still see them in the, if we, not even through VCT, we can catch them in other areas as well, if we limited the number of tests that we are doing under VCT. There are other policy issues which I wouldn't be able to discuss here, but all the message which we are saying is that we are still doing a high number of tests, but the yields are very low, even though we are getting high absolute numbers from these. So we need to use this data to inform us again on where we need to concentrate. It's the same thing which has been highlighted in the others. We have the polling question. Dr. Foloshi.
So the use of screening tools in outpatient departments can increase our chances of finding previously undiagnosed HIV cases. Are we going for true or false? Even the hub is welcome to vote. We are not immune from exercising our brains. So screening tools in OPD. I particularly like this question because actually when you go on the ground, we are testing people that are HIV negative every 3 months. And that is making our yield go down. By the yield, we mean how many positives? You've tested 100 people. Your yield, we mean of these 100, how many are actually positive? What are you picking from this? Because we are not that we are not interested in people that are HIV negative. We are, and we want them to remain negative. They should be linked to services. But there are those positive people. Is there a point in testing someone who's not sexually active every 3 months? Aside the pain that you inflict for people that don't like being pricked, it's a cost to the people that are paying for that. So that's why we are focusing on the yield. We are happy we are testing a lot of patients, but we need to test those that really need the test. I don't think if someone is negative, you need to test them every 3 months if they don't have risk factors. So I guess that's the use of the screening tools. We have 100% on true, Dr. Mulenga. So people think the use of screening tools can actually increase our chances of getting the positives. So there you go. You're already getting hints from from people on what we can do to improve our yield, to improve the number of people that are positive that we actually need. Oh, really? Yeah, it was more than 3 minutes. So
Domso, you haven't voted. You can tell us, maybe your answer is false.
Okay, so people are saying it's true. We'll run it again. It's fine.
Okay, right.
We have 48 slides. So
I won't go into detail of some screening tools that you'll be able to see. We're trying to do some adaptation of some tools which we have been looking at. And in those, it's looking at both at pediatric and also adult. We have to look at when someone comes to the facility, we have to ask those that have had an HIV test done, when was it done? If someone had an HIV test done and they are positive, it was a positive result, what we need to, we don't have to retest them. We need to accelerate them into care for them to receive therapy. Those that have had no test done, again, you have to screen them again to the to risk category. So we are going to look at the various risk categories, and with those various risk categories, whom should we prioritize for giving an HIV test? So I won't go into detail over these two, because very soon you're going to see some policy guidance over this, but this is the picture which we would like to have. And again, I need to emphasize to the group here is that we are not moving away from universal routine testing, counseling, and treatment. We are not moving away into that. What we are trying to identify is now as we identify these very few people who are positive, how can we prioritize in your facilities the testing? If someone has never had an HIV test and they want to have an HIV, they come, you screen them, you're going to catch them into there. So it's still under the universal testing. So we are not moving away from that. That's my emphasis on that. We need to go use these tools for us to identify those that we are not catching. And these two as well, we are going to, it's going to also to look at children. In the children, there are various things that are also going to be looked as well, or to be looked at, but the concept is similar. So these results showing that where you have applied certain tools, of course, the monthly data shows that there's reduced testing and also increased yield. So if you use it well, you're going to have a higher yield, but you have reduced the testing. So it's like you're getting more. So look at those who are the tests that have been done, HIV testing, the TST that is tested or tests done, not so many. Then the positives, the pos which you are able to see there from all those tests that have been done, how many of them are positive. And you can see that despite the reduction in the number of testing, the yield is getting higher. So this is the data which we're trying to use to inform us on how best to optimize the testing kits that we have, and also human resource as well.
Okay. There you go. Linkage.
So linkage is another big issue. Linkage and retention. We are doing well. I need to say that, we have scaled up the linkage registers, and the linkage has increased from 72% to 81%. We want to see 100%.
So these are people that have had an HIV test and they're linked to care?
To care, yes.
To ART. So
Yes.
there's a register that is there in the facility. I test for HIV, I'm in non-register. Then there's a register that shows now I'm being linked so that I get my ART. We don't want people getting an HIV test and walking away without ART, isn't it?
Exactly.
Because we're in the era of test and treat.
Exactly.
Okay.
So we don't want that, and you can see that the linkages, again, from the COP18 Q1, you can see their increased linkage as well. Let's move to look at the female, 50 plus, 100%. Yes. I will also the male 86%. Is it because us who are old, we know that we are about to die, so let's be put on treatment, we extend our years? We can do the same thing to the children. You know, we can do the same thing to these young men as well. Because we know that as long as we delay on linkage, this is a missed opportunity. If we delay on that linkage, what is going to happen is that there will be severe immune deterioration, and recovery is going to be, there will be no permanent recovery in terms of immune restoration. So linkage is very key, both at population for us to reduce the viral population level, but also it's at individual level as well. For one to have a better outcome, it's very important. So some of these things, let's not just look at them as programmatic indicators which you're looking at. They have a direct impact on that human being or that client who is in front of you. Now, retention is also linked to the linkage. Once we link someone to treatment, we need to put them on, we need to retain them under care. We have suffered, of course, and we'll go the few slides which are going to highlight where we have seen some reduction in the number of people that we are retaining. And again, this is not an issue just for our country. I think it's an issue for the whole region. It's a global issue as well. Our retention, of course, is slightly better than certain countries. South Africa retention is pretty bad. My colleagues from South Africa, Mozambicans, they were crying over the retention, and then now with the disaster which has happened, I don't know how. So we are not alone. Friends, other countries are still considering this on how best do we retain individuals. So if we are left behind, then we are not going to achieve this. The way we need to look at it, the HIV fight is that if we don't do things rightly here in Zambia, our neighbors in Namibia are doing things well, we are going to have the spread of the infection not controlled the whole region. And this is also the message which when we discuss with other colleagues in zero level in other countries, that we need to work together as a team so that we can fight this epidemic together, or else even other countries which are doing well are going to be affected.
So we will now go to our next core question. So this one goes, non-transfer of dispensation data from pharmacy to smart care and clients who are already on ART presenting for QR testing are a significant cause of artificial loss to follow-up. Non-transfer of dispensation data from pharmacy to smart care and clients who are already on ART presenting for QR testing are a significant cause of artificial loss to follow-up. So what's impacting our retention rate? Because people do look at data. You can't explain every patient if you're seeing 1,000, isn't it? Especially for facilities that are e-last. You enter your data manually, then you want to transfer it to smart care. One day you are tired, the next day you are tired, the other day you stop. And then also there are people that are presenting for QR testing. I don't know if we have any volunteer to explain what QR testing is. Any volunteers? So by QR testing, and I actually wanted to ask you this, Dr. Mulenga, if that may be accounting for some of these retestings we are having. you know, when you go to your pastor and they say you are cured, you need to be tested somehow, isn't it, as evidence? Unfortunately, in the program, have we planned test kits for those who are told by the pastor that they are cured? Because that's a huge proportion of people that are told, stop your ART, you are cured. But obviously the church will need some evidence. So they will present for cure testing, and they definitely will consume test kits. You know, as human beings, before we are physical beings, we are spiritual beings. So anyway, you have some answers there. Only 6 people have responded. I don't know how long we should keep the poll. So are we having an artificial loss to follow up because sometimes we are not putting the data into smart care, and some people are coming back for retesting just so that they are able to check if they are really cured? I don't know. Maybe the question can be interpreted or put in a simpler way. Maybe it's the cure testing that's confusing people. Only 6 facilities have answered, and I know we are joined by more than 40 spokes and individuals. What is affecting our loss to follow up? Because when we go to facilities, we say you have 60% loss to follow up. Are we having some artificial losses? Do we actually have these patients in our facilities, but because we haven't transferred the data, or some people are now coming back and being tested even if they are on ART, so we are losing them? So is it okay for me to stop sharing, Chatonda? Okay. So there are your results. Okay. So a lot of people think that it's true. Some of the loss to follow-up may actually be artificial. Okay, you have another poll question. So the other question is, the following are causes of true loss to follow-up. The other one was talking about artificial loss to follow-up, meaning somehow your patient is still in the system, we just are not capturing the data. So this one is on the true causes of loss to follow-up in Zambia. Is it because our clinics are too far, long distances? Do we have congestion in clinics preventing confidentiality? Do we have a lot of death from treatment failure or non-adherence? Or is it all these things that are making us lose patients? Why we are having poor retention? Why we don't have people in our database? Are people too far? Are our clinics too congested? Are people dying from treatment failure or non-adherence? I know our mortality remains high, 10 times that of Europe, despite having ART. So 8% of the network feels that it's because sometimes the clinic is too far. So today you start your ART, you carry your 3-month supply, and you're never able to go back because it's just too far. Some people feel the clinics are too congested. So there's no confidentiality, isn't it? All those with HIV stand on the left, all those who are negative stand on the right, we start giving drugs. So sometimes it's too congested. So I wouldn't want to come back if it's too congested. I've got work to do. So no one feels that people are dying from non-adherence and from treatment failure. And some people think it's all the above. I'm sure Dr. Zulu would like to speak to C, which is death from treatment failure and non-adherence. I think he sees these patients all the time. And sometimes when we phone our patients, we are told that they are dead, isn't it? So there we those are the results. I can stop sharing, Chatanda. Okay. Dr. Mulenga. Coverage.
So interesting, the way you've answered, especially the last one. Anyway.
Good.
But I'm sure after the end of this, you're going to see and you're going to find the answers. It's a variety of reasons why there is the loss to follow-up. Look at the data from Q1, December 2018. We have seen a drop in the ART coverage among pediatrics and men. You can see the last one, that is the Q1 we're talking of. You can see it was 62% for the children, moved now to 60%, again 61 to 60 across all, 79% to 77 for the females, 15 plus for the total, 71% to 69. Yes.
There's a drop.
Yeah. So again, this is worrying. Why are we not doing well in terms of retention? Why are we losing the patients? And the total loss to follow-up, I've seen of about 120,000. This is huge. But also look at the COP17. There was a 30-day. We have attributed this also to some where PEPFAR is now reporting the 30-day as loss to follow-up. Traditionally, we had been reporting at 90 days. So we look at the 90 days. So from 853, which was there in the COP18, you look at the COP17, when you look at the 30-day cutoff, you move the patient to 832. So again, there we have a loss to follow-up, an additional loss to follow-up because of the definition of 24,645. And as a ministry, we are trying to highlight and also align this reporting as well so that we see what is going to work better and we can have better improvement in the data if we are speaking the similar thing, whether it's 90 days or 30 days. So some policy guidance is also going to come over this piece.
Is there any reason why we're moving from 90 days to 30 days?
Mary would answer, but from the discussions which we have had internally, also quality. We don't want to wait for a long time before you can follow up and act on that individual whom you may easily get back. So if you are able to know from the last pharmacy pickup, someone has delayed by 30 days, it's better to effect your interventions other than waiting for 3 months. That's when you effect your interventions. Maybe that person may have died, or that person, you may have had a chance to bring back that person into care. So more of quality from our side. I don't know from the USG side.
The only other thing that I'll add is that the data shows that if someone doesn't take their meds, within a week, their virus already starts to appear. And then by a month, their viral load is significant. And if the goal is, not just the quality of that person's life, which of course is the primary concern, but also the fact that if they're now detectable, then they're transmitting. And it's just making the whole control of the epidemic harder. So the idea is the sooner, the better.
Okay, so the earlier, the better. I would imagine if somebody didn't come because they were too sick, you may be able to even save their lives if you reach them earlier than if you waited and you say, oh, they died actually a month ago. So it makes sense.
Yeah, but again, it's been a big issue in terms of implementation of this within the ministry side, and some uniform policy guidance is also. So a lot of policy documents to be made.
That's good. Saving people's lives.
Then in terms of tracing, again, these were the traced patients, 36,824. Comes to about 62% are still on ART relieving those that we think that they're lost to follow up. And how best can you?
It's the data, isn't it? Because you just need to capture it in smart care. So they're actually there. They are not lost. They are within the facility, but the data wasn't transferred. Maybe the staff were overwhelmed. Okay, I see.
And again, this is looking like for the largest loss in the NECNU was in Lusaka with that 38,594. Look over the quarters where we're reporting 91%, then you have 72%, and you have 60%. So again, this is worrying information. I think you can go to the next slide, which you highlight. So when you look at the number of patients you are tracing from the 19 facilities, those with the biggest decrease in the net new in Lusaka, the loss to follow-up was about 10%. But again, much higher among the patients who are on ART for less than 3 months. Now, again, these who are less than 3 months, especially with the older drugs, they may not be virologically suppressed. And again, if you can lose them, then you have the virus spreading around at community level as well.
Do you have any idea why it's these people that are on treatment for such a short period? Why the early patients? Why not somebody on ART for a year? Could it be that us as, I'm a frontline worker, so I'm always thinking about myself, maybe the message we are giving?
Dr. Chitembo, what would be?
Well, it's variation of reasons.
Okay.
Can't pinpoint one thing.
Or why we are losing more patients that have just started ART?
Sometimes counseling, I think, should be something that we still need more investments, because these are individuals, not numbers. And then there are a variety of individuals with different levels of understanding. Then the issue of ownership, it's about me and my health and my survival and me being on treatment. It's not about the healthcare worker. Then where is our concentration? Do the clients really get convinced of what they are starting? Do the healthcare providers also kind of provide more information and continue counseling? So that, because it's not a one day off and you forget. So maybe linking with the communities, what's the role of the community networks and how they are assisting in ensuring that continuously there is this continuous counseling.
Okay.
So there's some issues we still need to invest in.
If I could just add, the way I see it is HIV/AIDS is not very different from any other chronic illness. And I think that what patients go through is just the realization that this is a lifelong thing. And it takes a while for that to set in. Some of them will disengage after their 2 weeks of the new medicine and end up dying. And then, if we're lucky and we get the remainder, we need that consistent and continued counseling that you need for any major chronic illness. You can't get away from it.
Thank you very much, Mary. So for the network, if you have any thoughts about what we are discussing, please feel free to raise your hand and we'll be able to.
Sorry, can I add one more?
Minute, please.
This 3-month window is also when TB and other opportunistic infections are at highest risk of showing up in higher mortality. So although in this case you were able to track the deaths, some of that loss could be from iris type symptoms or some other reason that patients feel uncomfortable and disengage from care.
I just want to make a comment from the experience in the clinics. A lot of them have specific days, so that really makes the clinic very busy. So we really need to make a deliberate effort to have ART every day, because they test and start on any day, but then they're asked to come for review on the ART day, which may be on Tuesday or Thursday or just one particular, maybe 1 or 2 days. And that makes it very busy and discourages clients from, they fall out from early because of that.
What Dr. Okawa is saying, that sometimes maybe we are too rigid with the rules we want to place. So maybe if we are not having ART on that day, we may be open to seeing a patient. But I'm sure you'll talk a bit more about that, because I know there's a paper that was published with a very interesting title. I know it's in one of your slides. But I'm seeing a comment.
People-centered.
Yeah, patient-centered. It should be patient-centered care. So maybe sometimes we are losing them because Tuesday they can't come because the boss can't let them come. There's a comment from somewhere that they are saying sometimes patient preparation is very key during initiation of ART. This is from Matero. For example, if patients are not effectively prepared for treatment, it's easy for them to opt out, isn't it? So somehow you have to add that emotional layer to say, look, if you start your ART, you'll live as long as somebody who's not on who doesn't have HIV. This will prevent malignancies. Maybe we go a bit deeper in discussing why we initiate people on ART. But I think, as Dr. Chitembo said, there are various reasons, but we need to step up.
Right. And this issue of people moving from one facility to the other, people who have been on treatment, it's real. At 12 facilities, this was just picked. You do viral loads, and those people that are initiating treatment, those that are initiating treatment, you do viral loads. Ideally, you would expect them to have high viral loads. But you look at how many of those were suppressed. 24% of them were suppressed. So these are likely to have been on treatment from other places, and they've just come into another place. That's where they are testing. And this is would account for also the loss to follow-up and the retention rates, which are poor. I'm sure we've seen this in some places as well. Dr. Mpeta, in Ndola.
So Dr. Mpeta is doing a very important job of TOD transition on the copper belt.
Yes, Dr. Somba.
Yeah.
Am I being?
We can hear you very well.
Okay.
So, Dr. Mpeta.
Yes.
Yeah, are they seeing similar challenges as well on the copper belt of people that are initiating treatment, but they were already on treatment from other places? So when they do the viral load, they're suppressed.
We are actually just analyzing the data right now, as we've started by gathering all the data from the lab. So that's when we'll actually integrate by facility. Yeah, but I think it should be something that they are already seeing as well. And we will actually get the real picture when we move into the facilities by tomorrow. So today we opted to look at the whole provincial and data, especially the high volume sites, and then we move on. But we've seen quite a number of people are suppressed, and it would be interesting to correlate to which people actually, recently started ART. Yeah.
So really, when you summarize the retention, why over 60% of the 120 who are classified, they are still active on ART. Where we don't transfer pharmacy data to smart care. Then also patients, as we have been discussing, not disclosing their status, they're already on ART. So we believe that the current rates of loss to follow-up are high, and they also threaten our ability for us to put this HIV under control.
So by high, you mean even if it's a real one or one that's just due to data? That's a concern too, isn't it?
Yes. Because if we are talking of 60, so we have maybe about 40% of that. So that is still high. That's a high figure. And these are the reasons of the study Dr. Folosh was referring to, reasons which have been given on why people stop coming to our facilities, long distances, costs in terms of the patients for them to get to the facilities, the congestion, and that's why there are other priority areas which we are going into to avoid this congestion, understaffing, which will lead to long waiting times as well, then missing medical records which are missing, frequent clinic and medication visits, so we have to space and also give medications at higher levels. Is Petauke joined in?
Yes.
I want Petauke, I'll put them on spot. District hospital and the district pharmacy. There was a query which came from the president yesterday that Petauke, you are giving 2 weeks and also 1 month supplies of ARVs. Late in the night, I was asked by the minister to provide a ministerial statement in response to this.
Is it Petauke District?
Petauke District Hospital. But also if we have joined in the pharmacy, the district pharmacy.
From Petauke?
From Petauke as well. I think this is concerning the area member of parliament went there, and also the president had visited the district, and this came out. Now, some of these are not just for us to manage our leaders. They have an impact on that patient. If you are going to supply for 2 weeks a client, when we have 8 months of stock of TLE, we have 6 months of stock of TLD, we have no reason on why we should give drugs for a month to clients. We are contributing to this loss to follow-up. So Petauke, from now on, you'll be an example, the whole country, of how a program can be mismanaged because we are not doing the things well. On Monday, you see me in Petauke, I'll be there. Sorry to put them on the spot.
I know Petauke knows that Dr. Mulenga means it in good faith. So I'm sure there was something that could be explained, that's why they only gave 2 weeks.
No, it's because the commodities were not on site, the commodities are available. Mm. So, the stock management as well, it's going to lead to us losing the patients. And it may not just be in Petauke, it may be in other areas where we are not there, and because no one visited, and we are giving these clients 2 weeks or even 1 month. Now we're even saying 6 months. As the memo said, we gave a memo, say, let's give 6 months for those who are stable. So if we don't have the commodities, we are not going to have we are not going to supply them for 6 months. So this issue is very big, and let's please treat our clients very well by having the commodities available and also respecting guidance which we have given from the ministry. So 3 months multi-month scripting. In Zambia, we have 88% are doing that, but we are moving now to 6 months because we don't want people to be coming to the facilities and giving that as an excuse for them to be lost to follow up. So some of our solutions, again, is having the smart care. We roll out smart care so that we can truly determine those who are lost to follow up. And there are also the issue of introducing the fingerprint biometrics, so that would really have a clear hand on this. Viral load is another key thing that we track, and which we discussed before, and it's a priority area for the country. We have seen that the coverage has increased. I remember when we presented in October, we were just about under 30% coverage. We've now seen that this has increased.
So Howard, March, and Matera, I see you. We'll get into that. Just finish the presentation, then we'll go to them.
So this is where you can see the capacity which has been in place for us to reach the targets. So the testing capacity has been increasing. Overall viral suppression programmatic is about 83%. And you can see that we have better suppression in the older age group, lower suppression in the pediatric age group. Dr. Chitembo, Dr. Jinwala, we have a lot of work to do. Dr. Muya is not here, Dr. Thomas.
Dr. Boyd.
Dr. Boyd, yes, how am I sparing you, Dr. Boyd? We shouldn't be like Petauke.
Do we have any idea why we are struggling with viral suppression in our kiddies? What could be the things? Aside, obviously, they are kids. People say that kids, they depend on their parents or their guardians for ART. But I told my friend, he's a pediatrician, that actually also they depend on us, the healthcare worker. They depend on me to change the dosing when the child is bigger. So they are depending on so many factors for us to get to separation. But Dr. Jinwala?
We don't have the simpler one tab once a day type of until we get there.
And they don't have the simpler one tab. Dr. Mulenga, you asked a question. There's your answer. They want something simpler for them, eh? Yeah, maybe
something simpler is coming, doctor. We hope we are going to have better.
Yeah. So something better is coming for the pediatric population. People are looking at it. I guess we move on to the next slide.
Yes.
Well, if I can just add, some of the measures like transition out from MVP-based regimens, those are measures that people are implementing on the ground that will make a difference.
So people have heard the cry of the pediatrician, so people are looking into it. One tablet, transitioning to more efficacious regimens.
Exactly. And again, having a viral load is not just important for us to say, well, I ordered a viral load. We need to act on all unsuppressed viral load results. So if you have a viral load which is unsuppressed, you do enhanced adherence counseling. Viral load which is repeated, if they are suppressed, good. Those who are unsuppressed, if they are on first line, if they are on first line, switch them to second line. If they are on second line, do an HIV drug resistance testing and switch accordingly. Of course, the HIV drug resistance testing is dependent on the facility where we are. So the whole point is that with proper documentation, you have the viral load which has been done on a patient. It's documented and the file is taken to the results are taken to the file, entered onto the smart care. The clinicians, nurses, they act on it, and that would translate to better care for the patient and also overall a reduction in the population viral load. The TLD, Dr. Mpeta and team, this week we have about 10 doctors and pharmacists. They're on the copper belt trying to enhance the TLD transition. Next week, the doctors will be in Central Province. Dr. Nyak will be in Central Province and other pharmacists as well. The other week, Eastern Province also next week. We are covering the whole country so that we can increase this TLD. We have done so well. And I've been impressed with the results which have been coming in terms of how many patients that we are putting on treatment. We started very slow, but we have seen an increase, and I can assure you that we can do better. So congratulations to all, including Petauke, they're doing better on this aspect. Congratulations to the team out there. And as we move on as well, we need to emphasize that we have to follow the guidelines. And I remember in the guidelines, we have not said exclude the female of the reproductive potential. If they have contraception, give them. And also if you cancel them and they're still willing to take the DTG, give them the DTG. And I think this message has been going out there. So thank you, Dr. Fellowship. TLD has been discussed several times and we'll continue emphasizing this. So well done, team. We just need to give and keep up this momentum.
Client literacy.
Client literacy, everything, isn't it?
Exactly.
Knowledge is power. And I was at a facility in Southern Province called Kemba. I was very impressed. All the women over 49 years old were actually transitioned to TLD. So remember, we have an aging population, of which we have females that are also eligible for TLD. So that was exciting to see. I was really pleasantly surprised.
But do the people know that there's TLD?
That's a very good question.
Because yesterday I was chatting with one of my relatives.
Mm-hmm.
Actually, from Friday to Sunday, 4. All of them said they don't know. They're not aware.
Maybe we should make a song.
One in Ndola, 3 in Lusaka.
Yeah. So, we discussed if during the co-planning meeting of other models which we use the combine radio. When people are on the minibuses, they are busy listening to combine radio, not to Radio 4. We put this messaging there. We have the CS4s. They have the messaging for our portfolio, which they use to send to people. So we're looking at models using the health promotions unit, text messages. On Friday, I received messages of the TB. Even yesterday, I was still receiving messages about TB. Let's do the same about the viral loads. Let's do the same about the TLD and who is eligible. So I think the literacy is very important as well, which is linked to having undetectable viral load is untransmissible. So I think let people know that if I have undetectable viral load, my chance of transmitting to my partner is almost zero. That would also, I think, help them come out and say, I want DTG so that I can be undetectable within a short period of time. Then I won't be able to transmit the virus. And I'm glad that during this COP, there's more funding which has come to a faith-based initiative for the COP19. I don't know if under the programming, having comprehensive treatment literacy should be included in that. So as a ministry, we are excited over this, and we want to move using the health promotions unit in trying to identify which fora we can use for us to engage our people.
I love this conversation because I think knowledge is power, isn't it? Because I was giving a talk at Chais, and we know that even among us healthcare workers, there are people living with HIV. When they heard about TLD, they were so moved about it. You know, we need to make songs, you know, get the message out there that you can have a healthy life, have babies, as many as you want, if you're on the right treatment. So we need to do that demand creation as well. Okay.
Right. So another thing which we also highlighted during the planning meeting and which was discussed, and there was also funding coming towards this, is cervical cancer screening. Mary, sorry.
So cervical cancer screening, how are we doing as a country?
So we are not doing well for the cervical cancer screening. We are not screening. Remember now, all HIV infected individuals are supposed to be screened, and we are not doing so well.
Females.
The females, yes, of course. And the other issues we have looked at, maybe is it because we are depending on just standalone facilities which are providing cervical cancer screening? So we are looking at the ways of having the DNA testing for HPV, because 40% of those, we can remove 40% of those individuals may not really need to undergo under the VIA. Only those who are positive are the ones whom we can link for VIA. Then from the VIA, we can link them to the LEAP. So there are discussions of how can we use the gene expert to do the HPV DNA? How can we use the equipment like the Panther, which can do the DNA? We have the multiplex PCR in AIDC. You can do the DNA. So we're trying to mop up all these lab facilities which are available so that you can do the HPV DNA, and as a result, we may try and increase the coverage. So important, and even the mentors, those that are out there, as you go out, as you push the TLD agenda, you push the viral load agenda, you push the TPT agenda, you also have to push the cervical cancer screening agenda.
Okay, so it's not enough to suppress our women. We also need to get them into that cervical cancer screening as well, because sometimes even if you are suppressed, you are still prone to cervical cancer, isn't it?
Exactly. Exactly, doctor. Well put. So this TPT I've just highlighted on the issue of TPT. On Friday, we launched the new guidelines. And in those, I'm excited that we also advocated for having the 3-HP. Now, this is a high dose of isoniazide with rifampicin. Data came out 2 weeks ago in CROI that we can now give this 3-HP with dolutegravir. So even with TLD, we are okay to give this 3-HP. And there's good news as well. PEPFAR, Ambassador Bex promised that PEPFAR funds were going to be used to get the 3-HP. So once we have the 3-HP available on the market, then we should be able to implement this. We are reaching out also to other organizations, the UNITED and also CHAI, to include us on that 12 high priority countries. But also linked to this is that we need to have IMH also available. And also most of these are policy issues on our side. But we need to push the TPT agenda. We are 25% of those that are eligible. We are started on TPT. So we are not doing so well there.
Okay, so we hope that 3-HPT, which is the isoniazid and rifampicin, can lead to more people completing INH, because it's not enough for me to start INH. I need to complete the 6 months, but now it's only 3 months, because I was even worried, how would this affect my DSD? So 3 months sounds very, very attractive, and that drug interaction, there's no rifampicin, dolutegravir drug interaction, isn't it?
Exactly. Okay. And also, doctor, you know, when you're talking of those, of course, I need to say that right now what we have, they are separate tablets, but they are going to take them once a week.
Yes. For
3 months. And there's more data as well, which we're analyzing some papers which came out as well on the 3HP as well, the issue of the other dosing. But for now, what we have put in the guidelines is once a week of 3HP. In fact, we have now highlighted it being a priority. Then where we do not have the 3HP, then we have isoniazid. We have not put it as a high priority because Dr. Chitembo and team, and I want to disclose that they defeated me. So we said 3HP.
Should be prioritized.
Prioritized, yes, but we don't have it available right now, so it's isoniazid for now. So we need to go on out there. Don't say we have to wait for 3HP before we give people the preventive therapy.
So, I'm sorry, can I ask, in the new guidelines that were released Friday, you said?
Friday, yes.
They do include 3HP.
Yes.
Well, congratulations.
Thank you.
As far as I know, you're one of the very first countries with the updated guidelines.
Thank you. We did within a week. You see, Mary, we are working. We are working government. Thank you. Thank you so much.
Okay, so we've been reminded that we are using too many abbreviations. So what is TPT? What is 3HP?
Dr. Sombo, please, the chief mentor, explain to the people out there.
TPT essentially is just because we used to say IPT because we were only focusing on one drug. And as we've heard, very soon in country we'll have rifampicin and isoniazid combination. So this is just to accommodate all other treatments for prevention of TB, for treatment of latent TB. So we said TPT, so that even if I say TPT, it could be that I'm on isoniazid, it could be I'm on 3HP, which is isoniazid and rifampicin. But I think that's it. I believe this is your last slide, Dr.
And also the 3 is referring to that
3 months.
Giving, yes.
For 3 months, once a week. So very exciting. So we're looking forward to better things, but more abbreviations, more data to be entered. But I think this is exciting for us because at the end of the day, we go to a facility and we say, are your patients suppressed? Are your patients or an INH? But we're actually feeding into one patient. So I love this presentation because it brings everything together. That's why we go for work. It's so that we get people to suppression, so that we don't have people dying from TB. So I really love the way you did it.
Thank you. So what are the commitments from our side? And our side, I mean all of us, including those who are in Ndola right now, including Maryland, Dr. Sivile there, including our friends in Baltimore there. Our commitment is that the screening tool for HIV testing, we're going to relook at this. I'm sure within the next 2 weeks, you should have information on the screening tool. The 30-day loss to follow-up as the criteria instead of the 90-day, there will be policy guidance to be given. TOD scale-up, we are going to give, I think, big information or a big memo coming somewhere in May over TOD, I believe, if things go on well. Then the TPT, the scale-up has to be accelerated. Cervical cancer screening, point of care for EID and viral load. Dr. Lungu is not here, but we have agreed that we are going to use the gene expert, which is currently available for EID and also for viral load. He has accepted. Previously, we were fighting between the TB and HIV. It's now accepted. We just have to look at the mechanisms of how we use, especially for EID and also viral loads. Then we are going to go into a discussion for using the HPV DNA, looking at the cost as well for point of care. Then treatment and viral load literacy. These are key issues from our side, which we have to work on so that we can make the COP19 a people-focused COP. Thank you so much.
Thank you so much, Dr. Mulenga. So I guess going forward, people won't care about the number of visits and the number of tablets. They'll care about the quality of life that they get being enrolled in HIV treatment services. So we have a lot of feedback. There's a memo bigger than Dr. Mpeta going to come out on TLD. But do you want to speak about point of care, EID, and viral load just a bit, because we don't have this yet? So do you want to touch on that?
So the point of care, we're going to largely piggyback on the gene expert equipment, buy the cartridges for EID. The validation has been finished, apparently for both. EID, the report has been given. For the viral load, we are just looking at the report internally, but we are going to use largely the expert because we know that those are the ones which are available out there. There is also more expert which is being bought under the Global Fund.
Okay, so we have a comment from Macha. Macha, please go ahead. Chatondo, you can unmute them. Because I actually can't see them. Macha, please go ahead with your comment.
This is Dr. Spurrier at Matcha. Our comment related to loss to follow-up. We have found since test and start, we have quite a number of people who come once and don't come back. And we think that they're not really ready to start, although they say they are, and we start them in spite of a lot of counseling. We previously had 2 group counseling sessions and a 2-week lead-in before we started ARVs. Now we're starting them the same day. We have quite a few who don't come back at all. So I think that the test and start is another issue for the loss to follow-up.
Thank you so much. Miriam and Dr. Chitema, would you like to comment on that?
Yeah, that's interesting. I think perhaps, first, thank you very much for that information. Firstly, I would like to ask Marsha perhaps to give us numbers. And similarly, from the ministry, action point should be that let's collect information, data about what's happening, so that we start thinking about analyzing, is the test and start? How is it functioning? What are the implications? I think information coming like this, we can't just overlook it. There's need for action. And that action means let's collect data countrywide and see what's happening. And in zero progress, we can make some resolutions.
If I might just add, so it takes some time and innovation if you're going to change a practice that saves people's lives. So I guess my question is, are you asking that we eliminate test and start, even though we know that all the evidence out there shows that it saves lives? Or are you saying that we need to rethink how we are counseling to better address the fact that people are being offered to start treatment on the same day? Whether that means that you bring them in more regularly before they are then, followed up every 3 or 6 months or whatever. I think that I wouldn't say that the problem is test and start. I would say maybe the problem is perhaps that we need to relook at how we're offering counseling so that we can make sure that clients understand and accept something that's potentially going to save their lives as opposed to going backwards.
Go ahead, Dr. Rokaya. So, okay, I'm seeing a lot of hands up.
I just wanted to share an example from a specific clinic, McKinney GRZ, where we reviewed all the patients. They started offering treatment like maybe 2 years ago. So we went through a whole year of files, and almost 50% of those who were started never came back for the second prescription. So these are from a review of all the files of those who are on treatment. So it was quite shocking to see that with test and treat, we actually lost so many drugs
So we are having comments of losing patients who are on test and treat. But obviously, this is an evidence-based guideline why Zambia adopted test and treat. So maybe we need to go back. It's the onus is on us. Remember, it's about the patient, but sometimes it appeals to the inner being in the healthcare worker. I know ART works. I know that ART will prevent me having GI lymphomas, even at a CD4 of 1,500. So how am I as a healthcare worker delivering this message? So maybe there's something that we need to relook, because I think there's a genuine concern. What's the point of starting and then they're not back after 3 months? So I think that's a concern on test and treat. Would you like to say something?
Yeah, I think as Dr. Chitembo mentioned, we need that data, synthesize the data, and have more focused analysis and also focused group discussions with a number of patients that we may be able to get in touch with for us to have any policy declaration. So for now, still, we are going to use its policy. And if we feel that there's something that we are not doing right, then it's something which we can visit on how do we implement this in a better way. So thanks so much, Doctor, for raising that up.
Okay, so Howard, I know you had something to say.
How are you, Dr. Forrest and Dr. Mulenga?
Hi.
Okay, I think the question was raised based on the TOD transitioning. I think it was a concern from one of our pharmacists in here. So I think I'll give him the opportunity to ask the question.
Please go ahead.
I just wanted to find out, it's in essence the transition, not TOD necessarily, but the 400 equivalence. It apparently, as an institution, we have equivalent 600 in bulk quantities. So I wanted to find out if we can still use it, because I don't think we have to take it to waste. We still need to use it somehow. Now, I don't know if those people who have already been transitions to the 400 can still be taken back to the 600 so that we can finish it before it expires. But that's quite a long expiry date.
So because in addition to that, I think this has also been preventing the transition whereby people feel they have too much stock of TOE, maybe the 600 as he has put it. So that has also, because they're feeling like it will go to waste. So I don't know what's the stance. And also the other thing which I also want to add on top of that question, the drugs which for the patient who have transitioned, they are bringing back the drugs which they had, maybe after 3 months or they're on 6 months subscription or prescription. So what are we supposed to do with those? Because like the pharmacists also don't know where to take them. So maybe you can just give some kind of guideline on that one. So 2 questions in general. Thank you very much.
So one, we don't have TLE 600 centrally. So if we are still having TLE 600 in the facilities, it has to go. And also we are not going to have any wastage of products. But also I need to emphasize that the TLE is an alternative. So you have patients that are not going to be on TLD, and also you have patients that are not going to have a viral load available. If you have viral load available for 100%, then please let us know so that we can redistribute that TLE either 600 to 400 to those facilities where they have no viral load access and where those commodities can be used. Patients and transitioning and retaining the drugs. When a patient comes with a viral load, it's those patients who you are not given the drugs, who don't have any other drugs. So if you dispense the TLE 400 for 3 months, then you have done your viral load and the viral load comes out after 2 weeks. You are not supposed to get the drugs back. Let the patient finish those drugs at the next clinical pharmacy visit, then transition them to TLD.
Howard, how does that sound?
Okay. Sounds out of those on 6 months, we still wait on them, or we can still bring them back, transition them.
No, in fact, we have not said start calling those patients whom you have given drugs, call them back to come and give them TLD. We have said
okay.
A patient comes on clinical and for pharmacy review, look at the viral load, then dispense them the TLD. We have not said call them, whatever they are on, call them and give them this. No, that way you cannot run a transition like that. Then we are going to have expiries of the other commodities.
Yes. Okay, so we needed that clarification, definitely.
Okay, so I believe Matero has something to say. We are winding up now. It has been very interesting. Matero, please go ahead with your contribution. I don't know, can you see them? That way they have 600. That's the Wanika.
I think we need a Q&A. So do you do?
Sorry, Dr. Mpeta, please go ahead with your comment.
All right. Thank you very much, Dr. Soma. Dr. Mulenga, one of the issues I think I've found here, especially on the copper belt in Ndola, since I've frequented this place multiple times, every time I think information is transmitted. When you come back, you ask, why still are we having low numbers for transition? There's a meeting where we were told slow down because the stocks of TLD are down. So there's always this, I don't know where this misinformation is coming from, which I think it's quite frustrating. One of the words I use to just kind of encourage is that anyone who is preaching a gospel that is different from what we are coming with, I think that information should always be held in context, because there's always somebody who has come to visit us and has told us something different. And I think there are some facilities who have joined in the network, and I think they are also facing the same in terms of being given, no, don't do this, hold on to the TLD, no, do this, do this. So you'll find that is actually affecting the transition on the ground. And I think we have to make it categorical that if the information is not on headed paper signed by the peers, then anyone who is giving information contrary to what you have been told, that should not be implemented. Then secondly, about improving literacy, Dr. Mulenga, I should inform you that I was due to give a talk to the musicians tomorrow, but since I'm in Lusaka, I've since asked Dr. Zico, is he there in the hub? Dr. Zico Lunga.
He stepped out.
Yeah.
He has stepped out.
He's stepped out. I think probably we can just give him permission for half of the morning to meet the musicians. So there's this project with Harvard University where they want to use music as a way of communicating information on HIV. So I think we can use this opportunity in ensuring, because in the next few weeks, we have got all these big musicians in Zambia. I mean, the Kopala guys, the Lusaka guys, the Ephraim, the gospel singers, all of them are going to be at this meeting. So we'll have to provide this information and give them specific information that we need for them to add into these songs that they shall produce, and then they shall be running on all radio stations in the country. And I think it's going to assist us about the information on TLD, about the information of index testing, household testing, and all these alternatives that we are trying to ensure that we push up the numbers, including reaching men. And I think this is one of the areas I think that we can use music, because men are always listening to music. So I think probably we can just ensure that Dr. Zico does deliver that message, and then we shall definitely see information coming through music in that regard. Yeah.
Thank you very much, Dr. Mpeta. We'll make sure Dr. Zico does not sing, but gives the right information, because I believe that he can't sing. So do we have any other comments before we start winding up this very important conversation?
Just Dr. Mpeta, here on the copper belt, just inform and in fact, the whole country, that right now we have 2.5 million stocks of TLD. That translates to about 5 months of stock if we are going to reach the saturation which we have hoped for. So we still have a lot of commodities available. There is no fear. That information should not be used as the reason for delaying the transition.
Thank you very much, Dr. Mpeta. And that's, I want to confirm what Dr. Mpeta is saying. I was on the ground in Southern, and you find for 1 month, they haven't been transitioning. We've been told that there are low stocks of TLD. But then that's why it's important for us to sometimes go on the ground and really just clear these myths. Because sometimes information needs to be reinforced, and that's why we have things like ECHO. We go on the ground and we clear the things that are happening, that are affecting our numbers. Mateo, please go ahead with your contribution.
Thank you very much for the presentation. Hello,
yes.
Are you hearing me?
We hear you very well.
Thank you very much. So I had two questions. The first question was with regard to the low stocks and prescribing drugs for 1 month. I think like Dr. Mulenga mentioned, it's not only, was it Petauke? It's also with other districts that I won't mention, but one of the issues has been MSL not to have delivered for some time. So like in my districts where I'm operating on, there's been that problem of prescribing because of low stock. So patients have been given drugs for 1 month because of MSL not having delivered for some time. So I don't know what can be done. I think it would be good to make a follow-up with MSL. The second question is with regard to 6 months prescription. There's been a concern in some districts which are very hot. I'll give an example of Chirundu, where the temperatures are very high as 41. So what is the guidance on that? You know, the farmers personnel, they're saying no, 6 months, not feasible. All the providers are very much ready and willing to go ahead with the 6 months prescription. So what are the clarifications on those 2 points? Thank you very much.
Nathan.
Nathan, thank you for that information. Kindly provide through Dr. Fellowship all those facilities where we are having challenges with stocks. And immediately we inform MSL. The issues we are talking of, like Petauke, was not an MSL issue. It was an issue which has to do with the management between the two. And it's sad if it's MSL which is hindering the progress. We'll have to quicken that process and sort it out permanently. It came to my attention of places where it's very hot, where people are saying they cannot give 6 months. Now, if you live in a hot area, you're given drugs for 3 months. I'm not a pharmacist, so I don't know if you're given those same drugs for 6 months, if 3 months, they're good for 3 months, but they're not good for 6 months. I don't know if there's a study which has been done which says if the temperature is high, the drug can only be available at that high temperature for 3 months instead of. So if we are losing the efficacy of the drugs because of the temperature, the storage, then you should give. Is it daily then? They should just come in and pick the drugs daily instead of allowing the drugs for them to go. So we don't have any evidence, as far as I know, of if we keep those drugs at that room temperature, and I don't even know that room temperature, most of them are very low temperatures. So I have no fear that they should not dispense the 6 months. Policy is 6 months until we have evidence that we are losing these drugs.
Okay, thank you very much. Macha, please go ahead. Just be very brief because we are now winding up this very interesting conversation. Yes, because there have been concerns about the temperatures in our country and people have been worried about carrying 6 months supply home. I'm not sure if there's data to that effect. Macha, please go ahead.
We only had one question and we asked that.
Okay, thank you so much. In conclusion?
I think Dr. Chitembo then now highlight just 2 seconds.
I think the way forward is that the numbers we saw It means people living with HIV, tested or linked or on treatment or virally suppressed. And then we saw the targets. Targets can only reach where we saw because of individual facilities ensuring that they are moving towards their own set targets. So for us to get wherever we want to go as a country, it must be responsibility of each and every unit facility to ensure that they take care of their people, their catchment population. They do all that is needed from the provider side, just like from the client side. That's the way to look at it.
Yeah. Thank you, Dr. Chitembo. I think for me, my last words in a few seconds is that you people are doing great work. I think we need to congratulate you, but it's not time for us to relax. We still have, with these last numbers we are talking of, we need all of you out there to be on board so that we can succeed and put the HIV under epidemic control. Let's look at the numbers closely, and the granular analysis of this data is very important as we go into the last phases.
Thank you so much, Dr. Mulenga. It's very exciting to see that we are moving forward with this epidemic. We are moving away from the time where we used to see people die because there were no drugs for HIV. So we've made big steps. We need to remember this epidemic is a serious one. We can see numbers and smile about it, but we need to do better than this. We need to get to 0 new infections because no one should die from HIV-related illnesses. So next week, we are talking about hepatitis B part 2. Dr. Michael Vinica will be with us at 14:30 on Monday. Thank you all for joining us, and it's a wrap.
And apologies for all those that made comments. We've just run out of time. It's been an exciting discussion. We have not ignored you. Please turn up next week and send your registers. Thank you.
To be covered.
Yes. We're going to break down this whole presentation into small bits because it was a lot of numbers. We realized that. So we'll make it into something that's more easy to digest. Thank you.